Everyone, welcome to researchmd.com. We got another great topic today, hypercalcemia. We've been going through a series of electrolyte lectures, and today we're going to teach you everything about hypercalcemia under 9 minutes. Our goal is 9 minutes. So make sure, you repeatedly watch the video so it will stay in your brain for a long time. It's very important for long-term memory, repetitively watching the video. Okay, again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents on a regular basis. I'm also director of research. So let's get into our topic. So what is hypercalcemia? Okay, ionized calcium greater than 5.6, total calcium greater than 10.6 after you correct for albumin. So primary hyperparathyroidism is the most common cause. And then you got hypercalcemia is rare in children, malignancy hypercalcemia, reported in less than 44.1% of all patients with cancer. So malignancy-related hypercalcemia, just be careful about it. So first, let's talk about the calcium homeostasis. Calcium level maintained in a narrow range by body from 8.4 to 10.4. If it is, for ionized calcium, it could be from 4.5 to 5.2. Like all the other electrolytes, you have a bigger range, but calcium, I think, is like another narrow range. Okay, it's maintained through serum iron and calcium level, which are regulated by calcium regulating hormones. What are they? PTH, biologically active vitamin D, or calcitrol, calcitonin. Those three hormones we need to know. And corrected calcium for albumin, corrected calcium is equal to measured calcium plus 0.8 into 4 minus albumin. Okay, remember that formula, it's very important. So if you look at the calcium metabolism, it's important to know when you have low calcium, PTH release, parathyroid from the parathyroid hormones, and kidneys reabsorb the calcium and excrete phosphate, and then it can act on the bones also, releasing more calcium, and the phosphate will be released into the bone. Okay, so classification of hypercalcemia, you can say mild, moderate, and severe. What is a mild? Greater than 10.6 to 12. Moderate 12 to 14, and then severe is like 14. So depending upon the symptoms, is kind of different. Usually like mild, usually like asymptomatic. If it is moderate, you can have fatigue, malaise, anorexia, impaired mental concentration, constipation, polyuria, and polydipsia. If it's total calcium greater than 14, you can have nausea, vomiting, dehydration, pancreatitis, cardiac arrest because of all the electrolyte, EKG, arrhythmia. If it's very common, stupor and coma itself, patient will die. Okay, so risk factors for hereditary endocrine syndromes. What are they? Familiar hypocalcemic hypercalcemia, familiar primary hyperparathyroidism. You got MEN1. Recent immobilizations, especially if the patient is young, can cause hypercalcemia of immobility. Okay, so that when you look at the causes, you can put them into two different categories. One is PTH independent and then PTH dependent. Okay, PTH independent, you got malignancy, osteolytic, PTH related peptide, which is in the squamous cell cancer and the renal cell cancer, elevated vitamin D, increased intake, increased conversion, granulomatous disease, TB, and sarcoidosis. And normal vitamin D, you can have calcium intake, low excretion, medication, theophylline, hypervitaminosis A, and increased turnover, endocrinopathy, and immobility. Okay, those are the PTH independent, malignancy, vitamin D, normal vitamin D, calcium intake, low excretion, and theophylline, all of that. Now look at the PTH dependent, you got primary hyperparathyroidism. It's more common. Adenoma, hyperplasia, carcinoma, MEN1 and 2, lithium, secondary hyperparathyroidism, vitamin D deficiency, tertiary hyperparathyroidism in end-stage renal disease. Okay, pathogenesis, again, calcium metabolism, skeletal, contain 90% of the total body calcium, with only 1 to 2% in the circulating freely. Only 45% of the calcium is physiologically active or ionized or free. The remainder is bound to inorganic molecules, especially like albumin, phosphate, bicarbonate, citrate. Okay. Now, hypercalcemia may result from increased bone resorption, increased intestinal absorption of calcium, and decreased renal excretion of calcium. All of this could contribute to hypercalcemia. Let's look at the signs and symptoms. Everybody know Moans, bones, stones, thrones, and groans. Okay, moans, you kind of put the psychiatry like depression, anxiety, irritability. Okay, then you got bones, musculoskeletal pain. When you talk about the stone, it's like renal colic, right? When you talk about thrones, it's like polyuria, and groans, abdominal pain, severe constipation, pancreatitis, and peptic ulcer disease. Patient, the other symptoms can be like weakness, dehydration, mental obtundation, depends upon the calcium level. You can also have hypertension. Severity increases, patient present with, we talk about the mild, moderate, and the severe. And anorexia, when it like severity goes up, anorexia, nausea, vomiting, QT prolongation, cardiac arrest, okay? Nausea may be present for the following, usually within the first weeks of life, failure to thrive, respiratory distress, hypophosphatemia, relative hypocalcemia, hypercalciuria, and subperiosteal eruptions, rickets and fractures, okay? Blood test, you got serum calcium, ionized calcium level is preferred, or calcium is measured actually. You got PTH-related peptide is commonly elevated in the tumor, so you have to make sure it's not malignancy. Serum vitamin D level, 25-hydroxyvitamin D3, calcidiol in all patient, 125 dihydroxyvitamin calcitrol. If hypercalcemia is parathyroid hormone related, remember that, okay? And then look at the sensitivity and specificity. PTH-related peptide sensitivity is 32%, specificity about 95%. Let's look at some EKG changes. Sometimes, for the examination purpose, they can ask you, but it's very, very important when somebody is hypercalcemia, check the EKG, because you need to keep them in the hospital and treat it acutely, okay? You got prolonged QR interval, widened QRS complex, shortened QT interval. Sensitivity and specificity very high for that. And the rest you can do is like you can do urine studies, imaging studies, you can do thyroid, parathyroid ultrasound, dual energy extra absorptiometry, chest x-ray, genetic testing. We talk about some familial diseases, right? So we got a nice flow diagram right here. How to manage the hypercalcemia management. You mild hypercalcemia, serum calcium between 10 to 12, usually asymptomatic, no medical management. You avoid thiazide, lithium, high calcium diet, volume depletion corrected, and prolonged inactivity. All of those can correct it, right? When you look at the moderate, which is between 12 and 14, you got asymptomatic, you can do the following, stop the causes of the medication whatever causing. If it is symptomatic, you can do intravenous normal saline 300 cc per hour, and then biphosphonate, alendronate, and pamidronate. Let's look at the severe hypercalcemia. What do you do? Greater than 14, right? Intravenous normal saline, you got calcitonin, you got semispar, furosemide, biphosphonates, okay? Recurrent hypercalcemia and severe hypercalcemia greater than 18, parathyroidectomy, denosumab, and hemodialysis are the last options right here. Complications, what kind of complication patient can, again, nephrolithiasis, nephrogenic diabetes insipidus, severe dehydration, nephrocalcinosis can cause acute and chronic renal failure, gastrointestinal causes, constipation, pancreatitis, you have to be very careful, peptic ulcer disease, cardiovascular complication, we talk about the arrhythmia, you got vascular calcification, valvular heart disease, and skeletal complications can include osteoarthritis, fibrosis, joint calcification, and fragility fractures, okay? Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel and hit that like button. Thank you again.